MetCUE, but I work at METC with the 68 Yankee ophthalmic technician students and the Air Force 4 Victor ophthalmic technician students. I have y'all for 8 lectures and a lab. Typically your lab for us will come towards the end of our instruction, and this time it's like pretty close to the beginning. I think y'all's lab is on Wednesday morning. The lab's actually going to be at my building in MIT 5 in METC land, which is interesting because you have to deal with all the students there. But in the lab, you guys will learn how to do what's called a Morgan lens, which is how we irrigate eyeballs if you get a chemical injury. And I'll also give you a little tutorial on how to use a slit lamp. That may be the first and last time you ever use one. But you'll at least have some basic knowledge of a slit lamp, okay? I have 8 lectures. We're going to cover the eyeball from front to back. Diseases, a little bit of anatomy here to start. But diseases and how you guys should be managing them as physician assistants, okay? By no means do we expect you to be subject matter experts on the eyeball. But there are things that y'all can do to make my life easier, and the ophthalmologist's life easier as well, and your patient's life easier, because a lot of things y'all can do in your clinics, but there are a few things that you probably shouldn't do, and you should punt to either myself or ophthalmology, okay? So hopefully I'll be able to convey all of that information to y'all. We follow the PANTS blueprint quite a bit. There's a test at the end. Okay? I don't think it's hard, but I also wrote it. So it's 50 questions. It's your standard tests. There's pictures. All the pictures are from the slides, so I don't add anything new. I'm trying to actually get rid of pictures because sometimes the internet in here doesn't load the pictures. So I'm trying to get the new questions that I add are mostly vignette style. We do have a couple questions that are just basic anatomy, but most of them are vignettes, placing you in a scenario and trying to either diagnose a disease or kind of the second order questions. How would you treat the suspected disease? Okay. Does anybody need a really good grade on my test? Pass this block. Good, cool. That's really easy. If you guys need extra help, I will be available either between the breaks. You can email me. That's probably not as beneficial. I don't have office hours either, and typically, historically, that hasn't been an issue for anybody. So, ask questions as we go along. Keep in mind, I do judge y'all on the caliber of question that you're asking. So think about your question before you ask it. But I'll answer all questions, whether they're intelligent or not as intelligent. All right. So this is the PANTS blueprint for your test. Okay. For the PANTS test that you guys have to take, this is what is all on there for eyeball-related disorders. Quite a bit, but we'll cover all of it. Some a little bit more in depth, and some things like conjunctivitis have multiple subsets. So just be prepared for that. The way we break the lectures down kind of works front to back. This first lecture that I'm going to give you is dealing with kind of a review of ocular anatomy and physiology. There are like a couple test questions, so don't just ignore this lecture. But again, most of those test questions for anatomy should be pretty easy for y'all. Okay, so before we get started, anybody tell me the difference between an optometrist and an ophthalmologist?
Surgery.
Yes, very good. Ophthalmologists are surgeons, They are either MDs or DOs. So they go through their 4 years of med school, and then they do a 4-year ophthalmology residency, and like a 2 or 3 year ophthalmology fellowship, whatever they're going to be specializing in. Where I just had to do 4 years of optometry school, and then I was able to start practicing. So you asked, why aren't you an ophthalmologist? And that is why. I did not want to do all that extra learning. Also, I did a prior Air Force. So is this just Air Force and Army in here? Oh, there you are. Hello. So on prior Air Force, I did 6 years enlisted as an optometry technician, and then I got out and did all my schooling, and now I'm back in the Army. Why I'm in the Army is your next question, because I was in the Air Force. Why would I want to join the Army? They paid for my school, and that is why. Several $100,000 of reasons why I'm in the Army. And the Army is actually pretty great, I've learned. So, all right. Basic ocular anatomy is what we're going to talk about here today, and then kind of things that y'all should be doing if you're doing an eye exam. Which again, you're probably not going to be doing an eye exam, but if you have a patient coming into your clinic that's got some sort of ocular issues, there are a few tests that you should be performing to try and help you diagnose whatever is wrong with the patient. And also, if you need to refer the patient out, it's good that you document the information from these tests in your referral as well. Okay, typically we like to start, as I said, from the anterior portion of the eye and work our way posteriorly. We do that with the diseases and also with the anatomy. So in the front of the eye, you can see you have two eyelids, right? Those are called palpebrae. And the space between those two eyelids is called the palpebral fissure. So it's pretty common sense as to what your eyelids are there for. They protect your eye. Okay? Your blink reflex, anytime something gets real close to your eye, you blink naturally. Those eyelids are there to protect. Well, less known is that they actually aid in how your tear film is spread across your eye. Your eyelids act almost like a windshield wiper or a squeegee on your cornea, and they spread the tears out. So if you guys have dry eyes, if you blink, usually your vision will clear up after you blink. Your eyelids contain a bunch of glands called meibomian glands, and these glands secrete oil. And that oil is actually the outer layer of your tear film. So there's 3 layers to your tear film. There's the oily outer layer, and that prevents the tears from evaporating. Okay, you can think of like an oil slick on the road. If it rains and then oil gets on top of that water's going to stay there longer because that oil is preventing it from evaporating. It's the same concept on your eyeball. The oily meibum from your meibomian glands prevents your tears from evaporating. And then you have the middle layer that's called aqueous. Okay, the aqueous is what hydrates the eye, keeps it moisturized, provides a little bit of nutrients. That aqueous is produced in your lacrimal gland, which is kind of up here temporally, superior temporally, on the side of your head. And then you have like a mucus layer, and that's what actually sticks the tears onto the cornea and keeps them adhered. Otherwise, they just run right off. So 3 layers to your tear film, and the meibomian glands secrete that oily outer layer. Okay. Where the eyelids come to meet, the superior and the lower lid, on the sides there, it's called a canthus. And you have a lateral canthus, obviously, on the lateral side of your face, and a medial canthus medially. Pretty self-explanatory there. Okay, the lateral canthus is going to be important for you guys to remember when we're talking about ocular trauma. There's a condition called orbital compartment syndrome, where you get a bunch of retrobulbar bleeding, causes a lot of issues for the eye, a bunch of swelling around the eye. We see this operationally on the battlefield more, especially in these newer conflicts that are dealing with drone warfare. There's a lot more head injuries that are taking place operationally now. And so orbital compartment syndrome is an ocular emergency that we'll talk about later on in the lecture series here. But you have to perform what's called a lateral canthotomy canthelysis, where you snip the lateral canthus and relieve some of that pressure behind the eye. And then there's two canthal tendons that hold the eyeball in place, and you actually snip those as well. That's the lateral canthotomy canthelysis. And that alleviates that pressure, and it's a sight-saving procedure because it allows a place for that blood flow to drain out of and gets the tension off of the optic nerve. If patients don't have that procedure done within an hour, they can be blackout blind in that eye. So, will you ever have to perform that? I sure hope not. But it's possible, and that's why I teach you about it. Okay. All right, there's some muscles in the eyelid. 3 of them that we are concerned with. Okay, the first, who's a good reader in here? Who wants to take a stab at the pronunciation of that first muscle? Orbicularis oculi, very good. When I ask my 18, 19-year-old enlisted soldiers to read that, I get much different answers that aren't really close to the word, but that was a good job. Orbicularis oculi. Okay, this muscle is a circular muscle in the upper and the lower lid, and it closes the eyelid, okay? And it's innervated by the 7th cranial nerve, the facial nerve. So the way we can remember that is 007. Right? Think James Bond, 007. Orbicularis oculi is innervated by the 7th cranial nerve, and that closes the eyelids. Right? So if a muscle closes the lids, we need one to open them, and we actually have 2. But the main one is the levator palpebrae superioris, the LPS for short. This levator palpebrae superioris is a mouthful. Now this levator muscle is actually in the upper lid, okay? And it opens the upper lid up, okay? And that is innervated by the 3rd cranial nerve, okay? So to remember the levator, you could think like an elevator. Elevators go up. The levator opens the eyelid up, okay? And then there's an kind of an accessory muscle that also opens the eyelid, and that's Mueller's muscle. Mueller's muscle is innervated by the sympathetic nervous system, okay, the sympathetic branch. And this is the kind of that fight or flight muscle. So if you get startled, there are many things that happen to your body, but your sympathetic nervous system kicks in, and it's going to activate Mueller's muscle, so it opens your eyes up really wide. Okay? And the sympathetic nervous system is also going to dilate your pupil a little bit, and that allows your body to see more and react to anything that's around you that's causing the fear or surprise. And then you start to sweat as well. Right? And then there's a bunch of other things that happen. But predominantly, that's what I care about. Okay? So Mueller's muscle, levator, those are the ones that open the eye. And the 007 orbicularis oculi is the muscle to close the eyelid. Okay, this is a picture of what these muscles look like. You can see the levator in the superior lid there, and then the orbicularis oculi in the picture on the right is in both the upper and the lower lids. Now, one of the main complaints that I get every single class, and feel free on your surveys to complain about it too, is the inordinate amount of slides that we have. It's a lot. I agree. It's a ton. I will say most of our slides on the real long PowerPoints are pictures. So we do add a lot of pictures. I think that helps to aid in your learning. And if you don't like it, again, feel free to write that in the comments. And I probably won't change it like I haven't for the last 3 years. All right, this is what the eyeball itself looks like. And we have three circles, essentially, 3 spheres. Okay, we call each of those spheres a tunic. And each of the tunics has a certain characteristic to it. So the fibrous tunic is made out of like collagen fibrils. So it doesn't have any vascularization to it. It's all collagen, elastin, all of the fibrous material in the body. And in the fibrous tunic, we have the cornea. Okay, the cornea is that front surface of the eye, the clear part. Okay, you can see the cornea right there. The lens is a part of the fibrous tunic, and the sclera is also a part of the fibrous tunic. Okay, those are avascular anatomical features of the eye, and they're made of collagen or elastin. They have to be clear, cornea especially, and the lens, because if they're not clear, it's really hard to see through it. Okay? So the cornea is kind of that main refractive component to the eye. And then we have the vascular tunic. Okay? Pretty self-explanatory. That contains the blood supply to the eye. So there are a few muscles inside of the eye. There's the ciliary muscle, which allows your lens to constrict and see things up close. There's the choroid, which supplies blood to the retina. And then there's some actual vessels that we'll talk about in the retinal section that also supply the retina as well. And then we have the nervous tunic, and that contains the photoreceptors in the retina and the optic nerve, cranial nerve 2, that goes back to the brain. Okay, so fibrous tunic, the vascular tunic, and the nervous tunic are the three main spheres of the eyeball. All right. So again, fibrous tunic has the cornea and the sclera. The cornea itself is a major refractive surface of the eye. Okay, so most of the light that comes into your eye is bent or refracted at your cornea. Okay, who's had refractive surgery in here? Very good. PRK or LASIK? PRK. Raise for PRK. Okay. LASIK. Smile. No smile. Okay. That's an actual refractive surgery procedure as well. Describe the difference between PRK and LASIK. Yeah, good. So both of the procedures, PRK and LASIK, will take a laser and actually reshape your cornea to allow the light rays to be refracted so that they come to rest on your macula, which is the sweet spot of your vision. That's your 20/20 vision. Light rays either are refracted too much on your cornea if you're too nearsighted, and they'll be aimed in front of your macula, or you don't have enough refractive power in your cornea, and the light rays are actually come to a focus behind your retina. Okay, so refractive surgery or PRK, LASIK, they will reshape the cornea and allow those light rays to be perfectly on your macula, giving you your 20/20, 20/15 vision. Okay? LASIK, as you said, cuts a flap into your cornea, kind of a lateral flap, and they'll flip that flap over of your cornea and zap, zap, zap on the cornea, reshape it, and then they'll put the flap back in place, and then you can see pretty well, and you have a much more comfortable time in your healing process, because they haven't created too much damage to the parts of your eye that become painful. Okay? PRK, on the other hand, does not cut a flap. Instead, they will take, they'll numb the eye, and they will put like an alcohol solution onto the eye, which will wipe away the corneal epithelium, the outer layer of the cornea, creating essentially a gigantic scratch, corneal abrasion on your eye, and also making vulnerable all the nerves that are in the cornea. And then they'll use the laser, zap, 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 and then that corneal epithelium actually grows back in place. That takes a few days. I had PRK. One of the worst, it's a great overall experience, but like the healing process in PRK is pretty terrible. I am a big baby when it comes to my eyeballs, but I was in a lot of pain after PRK. I was extremely light sensitive. I was in a dark room. I had sunglasses on and like my hood pulled over and my eyes closed. I still thought it was too bright. It was terrible. But a couple days later, it's all good, and I had PRK, gosh, almost 20 years ago now. I can still see what time it is on the clock back there. So ended up working out well for me. Eventually, in a few years, I'm going to need reading glasses, but that's because I'm going to become presbyopic because I'm getting older, which is back to life. All right, so the sclera then is the white part of your eye. Okay, that's the, yes?
You might have answered that, but what I was looking for, can you get a progressive surgery? Like, can you have LASIK and then PRK, or is you one and done for life? Or
no, great question. So if you had one type of refractive surgery and it maybe isn't as clear as you want, then they can go back in and do an enhancement, whether that's PRK or LASIK. You're not really locked into one or the other. But in terms of your near vision and presbyopia, that's a different system that we'll talk about here in just a sec. That's not correctable. So LASIK and PRK are for your distance vision. So if you can't see the clock on the wall back there, you can get LASIK or PRK for your distance vision. Any 40 or near 40-year-olds in here? Oh, you're still younger than I am. I'll be 39 in November. Sucks. Who's older?
There's one person older.
Oh, who's older? Who's the elder statesman? Oh. How old? 43. How is your near vision? Are you starting to notice that it's...
Yeah, everything was good. I think at 40, actually recently, so, I went for eye check and all those things like that, because when I was sitting here, so that I can see the screen over there, but I cannot see this one sometimes properly. They give me eye drop and then they give me glasses. So they said I can wear glasses if I want, but my eye is still good. I can just use eye drop. But to keep both glasses just good.
How's your computer screen? Is that blurry yet?
So if I'm too close.
If you're too close, yeah. Exactly. So it's going to continue to get worse. Yeah, which kind of sucks. But again, I think it's better to get older than to not, because that means you're dead. So.
At first I was relaxed because so I thought it was a problem, like it's the age. It's the age.
Yeah.
I thought there's something else.
A lot of it is.
So, yeah.
And Father Time is undefeated when it comes to the eyeballs. So usually around the age of 40 is when things start to become a little blurrier up close. And unfortunately, it's starting to affect me. So my hand is starting to get pretty blurry right about here. And that makes me a little sad. It is what it is. I guess reading glasses are not the end of the world. Okay. That is a little bit of a side note. My least favorite patient that I have coming in the clinic is like a 45-year-old female that's never worn glasses before, that is now starting to have difficulty seeing things up close. Because I have to tell that 45-year-old that she's indeed 45 now, and her eyes are starting to get old. And that's kind of a dainty conversation that you have with the patient. So just keep that in the back of your mind. If you guys have a patient that's coming in, if they come to you guys, a lot of patients will come to you first, because either they get in with you before they can get into the optometry clinic, or they're just, for whatever reason, don't know that there's not an eye clinic that actually does the eyeballs. But you'll have patients that come to you guys first. If you have that patient coming in, probably just ask them the last time they had an eye exam, not just like a MedPros exam or an ASIMS exam. When's the last time you saw an eye doctor? And that's probably time to go see the eye doctor. Okay. What's that? Quantum? Yeah, quantum to me. Okay. Okay. Let's talk about inside of the eyeball now. We've got the iris and the pupil and the conj. Okay. Who's this on the screen? Baseball fans in here. Max Scherzer, very good. Pitcher. Is he still in the league? Is he? Who's he playing for now? Blue Jays? Baseball fan back there, very good. What do you notice about Max Scherzer's eyeballs? They are different colors. Yeah, very good. Max has what's called iris heterochromia. His irises are two different colors. Okay, kind of a rare thing, but it looks pretty cool. He's not actually wearing contact lenses. That's just how his eyeballs are. One of them has less pigment actually than the other does. So the abnormal eye in this case would actually be his blue eye, because it doesn't have pigment from the other eye. So your iris is the colored part of the eye. Okay, there are two muscles that make up the iris dilator and the iris sphincter. Okay, the sphincter, that's one of the many sphincters in your body. Okay, it closes the pupil down. Okay, so when bright light is shown into your eye, your brain says, "Oh, that's bright. I don't like that. I'm going to activate the iris sphincter and close that opening so that less light is able to get into the retina." Conversely, when it's dark outside, your brain's like, "I can't see anything. I need to open up the pupil," and then it activates the iris dilator. Okay. The pupil is nothing. Okay? It is a void. It's just the space. Okay, so there's no anatomical feature that is the pupil. It's just the space in the middle of the iris, basically. Okay. The conjunctiva, on the other hand, is something, and you're going to deal with conjunctivitis a lot in your clinics, especially if you are on an AIT or a tech school base, because, man, kids are pretty gross, and most of the students that I have are still kids, and they don't have great hygiene, and they make dumb choices as well. So you'll see a lot of conjunctivitis in your clinic. We'll talk about that Monday. I think I have you guys next on Monday. The conj is just a clear membrane. Okay, so it's hard to see with the naked eye. It's less hard to see when you're using the slit lamp, because that's essentially the microscope that we use to see the eye. And there are two types of conjunctiva. There's the conj that's over the eyeball itself. That's called the bulbar conj. Okay, and then remember we called the eyelids palpebra. So the palpebral conj is the conjunctiva on the inner layer of the eyelids. Okay, and then where those two conjunctives come to meet, we call that the fornix. Fornix, F-O-R-N-I-X. Fornix is going to be important when we're talking about chemical injuries or chemical exposure to the eye. So if somebody splashes a chemical into their eye, we need to irrigate that eye and get that chemical out or neutralized to not be caustic to the eye. But a lot of times that chemical will get trapped in the inferior fornix because gravity just kind of works that way. So you got to take a cotton tip applicator and actually just sweep the fornix to get all of the crud out of that patient's eye. Okay, then we got the ciliary body. Ciliary body has two main features. We're inside of the eyeball now, right around the lens. Okay, and the ciliary body has these little finger-like protrusions. Those are called ciliary processes, and the ciliary processes produce the aqueous humor that floats around inside of the anterior chamber. Okay, that's going to be important when we're talking about glaucoma. Okay, so we'll come back to that when we're talking about glaucoma. And the ciliary muscle is what changes the shape of your lens. Okay, so when you're under the age of 40, you have a nice flexible lens inside of your eye, and when you're looking at something up close, the brain automatically triggers that ciliary muscle to flex, which actually relaxes the lens and makes it more magnified. So you're able to see things up close because the lens inside of your eye is becoming thicker, more magnified. Just like a magnifying glass helps you see things up close, your lens does that too, until about the age of 40. And then the lens gets hard, and then you have presbyopia, and you can't see things up close. Okay. Then we have the choroid. These two, the ciliary body and the choroid, are part of the vascular tunic. The choroid is just a giant layer of blood vessels, arteries and veins, and it supplies the blood to the outer layers of the retina. Here we can see the anterior chamber. So the anterior chamber lies posterior to the cornea and anterior to the iris and pupil. So this space right here is the anterior chamber. That anterior chamber is filled with aqueous humor. And again, the aqueous humor is produced by the ciliary processes. This is the ciliary body right here. Okay? And the ciliary processes are these little finger-like interdigitations there that produce the aqueous. And then the ciliary body also has that muscle that flexes right here and right here. And that muscle will flex, causing these little suspensory ligaments. Those are called zonules. Those hold your lens in place. Okay? And when the ciliary muscle contracts, that will relieve the tension on these zonules, which allows your lens to become thicker. And then when the ciliary body or the ciliary muscle relaxes, that actually pulls tension on these zonules, which pulls your lens back flat, and that's what gives you your actual distance vision there. Okay. So we said the cornea has about 2/3 of the refractive components of the eyeball. The lens has that remaining third of the refractive power in your eye. About 15 diopters in the lens and about 45 diopters in the cornea for a total of approximately 60 diopters in your eyeball. Okay, now we're behind the lens into the main body of the eyeball, and we have the vitreous humor. Okay, vitreous is just a gelatinous substance, and it kind of acts like a shock absorber a little bit and keeps the eyeball round. Okay, now vitreous can get some. It can clump together as you get older, and those clumps can kind of float around, and those clumps can look like either little hairs or little cell structures. We call those vitreous floaters. Okay? Who has floaters in here? Yeah, see. If you don't have floaters, you probably actually do. Please don't go looking for them, because you'll drive yourself crazy, and you'll drive me crazy, because you'll be in my chair a lot. But floaters are normal. They're just little clumps of that vitreous gel floating around. Okay? And then we have the retina. Okay? 10 layers in the retina. I don't care that you know the layers. Okay? I don't care so much that I don't even tell you what the layers are. But the retina, essentially, if you want to think of it from a basic A&P standpoint, has photoreceptors. They're called rods and cones. Okay? Rods are what allow you to see motion and also have your nighttime vision, and they're your black and white vision as well. Your cones are located predominantly in your macula, so smack dab in the center of your retina, and those are what give you that 20/20 vision and also provide you your color vision. Any color deficient folks in here? Me too. Red, green, yeah, same. So you just have a little less than 6 million cones in your eye, and that's why you can't see colors quite as well. Same. It's not that you can't see colors, just colors aren't quite as, there's not as much contrast between different shades. So color vision is an interesting thing. I'm in a few, because I'm color deficient, I'm an optometrist. There's an optometry school here in San Antonio that does a bunch of color vision studies. And have you heard of the Enchroma glasses? They help with color vision. They don't, spoiler alert. I've tried them many times. There's a video online where the guy tries on the Enchroma glasses and he starts crying because he can see colors. That is such a load of crap. That is just not how they work. But the premise behind those glasses is that they act as like a filter to filter out a certain type of wavelength, which the goal then is to create more contrast between colors. I've tried 2 different types of those glasses out. One didn't work at all, and they're big and they look real goofy. My enlisted instructors took a picture of me wearing those glasses, and now it's on the wall of shame in our office. There was a second pair that actually helped a little bit, but I still failed the color vision test pretty heavily. So cones again, color, rods are your black and white night vision. Anybody have a dog or cat? Dogs are better. Yeah, so you let your dog out at night and it's real dark. And you ever notice how if you're looking at your dog centrally, like straight on, you can't really see your dog unless there's a lot of moonlight. If you see your dog at night, try not to look directly at it, but rather use your peripheral vision. You'll actually be able to see your dog quite a bit better at night if you're using your peripheral vision. Your cones are centrally in your retina, again, in your macula, and they don't see night vision at all. So if you're trying to look straight at your dog, the cones are being activated and those don't work at all at night. So actually, again, you have to use kind of your peripheral vision to see things at night, and then you can see your dog. It takes a little bit of training on the eyeball, but I found it helps quite a bit. Because I have a gray or a blue Weimaraner, and she gets real dark at night when there's no moonlight. So fun party trick there. Okay, talked a lot about the macula already. That's a very important aspect to your retina. That's where all of your cones are. Okay, that's centrally back in your eye. So if you take your pencil and you jab it straight into your eye, which I don't recommend, you would poke right through your macula. Okay, that's where your sweet spot of your vision is. That's your 20/20, 20/15 vision. That's where all of the cones are. Again, so your color vision is right there, and it's a very important part of your retina, obviously. There's a condition called macular degeneration, which I would assume most of you have heard about. That one's pretty well publicized. And that's where the macula just starts to degenerate. And patients that have macular degeneration don't have 20/20 vision anymore because their macula is not functioning. Okay? They also have a decrease in color vision because their cones are dying. Okay, you also have the optic disc. That's where the optic nerve inserts into the retina. We'll talk a lot more about the optic disc when we cover our glaucoma lecture, but basically it's kind of shaped like a donut, a round donut with a hole in the middle, and we assess the optic nerve. You guys, if I recall, have done some direct ophthalmoscopy, and you saw the optic nerve, and you saw the macula. Okay, I'm sure you did. And you assessed it based off of the script that you've been given. Yeah, it's weird. The way that you guys do your cup to disc ratios is, yeah, that's not actually how it's done. So 1 to 2 cup to disc ratio would essentially be a 0.5. We go in 0.1 all the way up to 0.9. So we're assessing the size of the cup to the disc itself. So a 1 to 2, you guys call it. Stop calling it that, unless CANS requires you to call it that. But if you say to an eye care provider they have a cup to disc ratio of 1 to 2, what the hell do you mean? It's a 0.5. Okay, so half of the disc is the cup. 0.3 to 0.5 is usually in that kind of that normal range, but yeah, we'll cover more of the disc and the nerve in glaucoma because glaucoma affects the nerve. All right. Back at the disc. That's your physiological blind spot, if you didn't know. Okay. There's a trick you can do. You close an eye and you've got an index card with 2 points on it. There'll be a certain distance away that one of the points just completely disappears because that point is over the optic disc, and there's no photoreceptors on the optic disc, so you can't see anything. Okay, so you can look that up on your free time. It's a fun trick. Okay, here's the eye again. More pictures. Basically, all of the things that we just talked about, front to back. Okay, we have some muscles that control our eye movements. We call those extraocular muscles. They're outside of the eye. Extraocular muscles. And these muscles are listed here. There are 4 rectus muscles, superior, inferior, medial, lateral. And 2 oblique muscles. Okay? The rectus muscles are super simple to remember what they do. The superior rectus lifts the eyeball up, call that elevation. Inferior rectus lowers the eyeball, depression. Okay? Depression is in lowering, not your mental state. Medial rectus pulls toward the midline, lateral AV ducts away from the midline. Okay? The oblique muscles are tricky. Okay? So the superior oblique does the opposite of what you would think. Superior oblique actually aids in depression, okay, and intorsion. Superior is intort, so sin, you can write down if you want. And then inferior oblique actually aids in elevation, and it extorts. Inferior people will extort, extortion. Here's a chart. This is a good chart to know. I'm going to put it down there. Okay, we have this mnemonic LR6 SO4 press 3. LR6, the lateral rectus, is innervated by the 6th cranial nerve, which is called what? The abducens nerve. Because what does the lateral rectus do? AV ducts, very good. AV ducts, AV ducens nerve. Okay, the superior oblique, SO4, is innervated by the 4th cranial nerve, which is what? The trochlear nerve, very good. Why do we call it the trochlear nerve? It goes through the trochlear pulley. Yep, very good. So the 6th nerve and the 4th nerve, that's all they do. They only do those 2 things. 6th only controls the lateral rectus, 4th only controls the superior oblique. The 3rd nerve, the rest are innervated by cranial nerve 3. 3rd nerve does a lot. Okay? Superior rectus, inferior rectus, medial rectus, and inferior oblique. Okay? The 3rd nerve also innervates what? We already talked about. The levator palpebrae superioris, very good. So 3rd nerve also innervates eyelid movements as well. Okay, so let's say the 3rd nerve stops working. Somebody's got trauma or a tumor, something's choking off the 3rd nerve. What is that eyeball position going to be looking like? Yeah, down and out. Very good. Because there's only 2 muscles that are working. The lateral rectus is pulling the eyeball out. The inferior oblique is, the superior oblique is pulling the eyeball down. So that eyeball is going to be positioned down and out. What else is the patient going to have? It's going to be drooping actually because it can't open. So the eyeball is going to, the eyelid is going to be drooping, and we call that ptosis. Okay, ptosis, spelled with a P, P-T-O-S-I-S, ptosis. Okay, so ptosis in a down and out eye means that the patient has a 3rd nerve palsy. Okay. You can have 6th and 4th nerve palsies as well. 6th nerve is pretty easy to see when you're doing your EOM testing because the patient won't be able to abduct their eye. It'll come here and it'll stop. Okay. 4th nerve palsy is a little more difficult to appreciate because you have other muscles that are kind of doing the same things that the 4th nerve does. But a lot of people with a 4th nerve palsy walk around with a head tilt because the 4th nerve and the superior oblique aids in the rotational movements of the eye. And if one eye is kind of rotated this way, if you're straight on, there's going to be a little bit of double vision. So the patient will kind of rotate their eye so that they don't, or rotate their head, tilt their head, so they don't have that double vision anymore. Okay, so if you got anybody walking around like this, you might have a 4th nerve palsy. All right, the EOMs are yoked, not muscular yoked like a bodybuilder, but yoked together like oxen. Anybody play the Oregon Trail, OG Oregon Trail. It's the greatest game ever for the dysentery. But they're yoked together like the oxen. They work together. Okay, so if you're looking to the left, okay, your left lateral rectus is firing, and your right medial rectus is firing. Okay, if you're looking to the right, it's the opposite. Okay, they're yoked together. Right. That's probably all I want to say about that. This is an interesting chart here. Kind of tells you what muscles are firing in which direction of gaze. Okay. All right, we're going to talk about the lacrimal system here. We already talked about the tear layers, 3 layers there. Okay, oily outer layer from the meibomian glands, the aqueous, watery middle layer, and the mucus layer that keeps the tears on the eye. There are some structures here: the lacrimal gland, the 2 punctums, upper and lower, the 2 canaliculus, upper and lower, and the lacrimal sac and the nasolacrimal duct. When we cover our lacrimal diseases, lid and lacrimal diseases, each of these anatomical features can have a disease associated with it. Fortunately, they're really easy to remember because they're all named after the anatomical structure. So as long as you know the anatomical structure, you'll understand those diseases. All right, when you're conducting an eye exam, visual acuity is the most important thing that you guys can take. Hopefully all of you have some sort of like paper chart attached to the wall, and you have the patient stand 20 feet away from it, and you can get an easy visual acuity that way. It does not take a rocket scientist to take visual acuities. Anybody can do that, okay? But that's a really important measurement for eye care providers, whether it's myself as an optometrist or usually more importantly the ophthalmologist when you're writing your referrals. You want to make sure you have some form of visual acuity in the referral note. It really helps in how we diagnose patients as well. Okay, other things you can do would be extraocular muscle testing. Okay, you can test 1/3 of the cranial nerves if you're doing EOM testing. Sorry, 1/4 of the cranial nerves if you're doing EOM testing. DO, if you are comfortable doing direct ophthalmoscopy, you can do that. It's much easier to do if the patient's dilated. It's really hard to do if they're not dilated. Plus, like if you're doing DO properly, you're essentially making out with your patient. It's not the most fun thing to do, unless the patient's your spouse. And then you can test pupils, right? You don't need a fancy device to test pupils. Your flashlight on your phone usually works adequately enough. Excuse me, just shine a light into the pupils. You're testing the direct response of that eye. You're testing the concentric response of the other eye. You can do the swinging flashlight test to check for an apparent pupillary defect. That's super simple to do. Takes no time at all. You can check intraocular pressure. That's the puff test. That's the most enjoyable test that we perform on our patients, the puff test. Anybody not had the puff test done? I'm lying. It's actually not that enjoyable. We puff air into your eye and jump back. It's not super fun. But we're testing the pressure inside of the eye. Okay? Separate from blood pressure is intraocular pressure. If you don't have a puff test, you can use a tonneau pen if you have that, and we'll show you what that looks like here in a sec. You also could do digital tonometry using your digits, fingers. Okay? If you close your eyes and you palpate your eyeballs, they should feel kind of like a firm grape. Okay? If they feel softer than a firm grape, you have a low IOP, and if it feels like you have stones in your eyes, you have a very high IOP. Okay? So if you don't have fancy tools, use the tools that you have. Okay? I can get a pretty, it's not super accurate, right? I can't tell the exact IOP measurement, but it's usually good enough to determine the level of severity for a patient. Okay? Here's an eye chart. I would assume you guys have covered visual acuity already. Yeah. Okay. Remember the higher the number on the bottom, the denominator, the worse the vision is. Okay. This is a near card All right. Visual acuity. We do consider that a vital sign. And when you're documenting in MHS Genesis, that is one of the vital signs that transmits forward. Again, review OD's right eye, OS is left eye, OU is both eyes, CC is with correction, SC is without correction. So if you're recording distance visual acuity, this is what it should look like in the medical record. Okay. Let's take 10 and start back up at 14. Remember, you're doing that muscle H test. You're having your finger or whatever thing. It does not have to be technical. You can literally just use your finger. Have the patient look at your finger, do the H up like this. That tests all 6 EOMs. Okay. If anything's abnormal, you're going to document that. Like the patient couldn't look down to the right or whatever is abnormal. If you want to try and isolate what muscle is not firing, be my guest. But what you should do then is punt. Okay? If something's wrong with their eyeballs, probably punt that right over to ophthalmology. Okay? All right, this is what you should have seen when you were doing your DO exam. Yep, I'm sure. Again, that's what you saw. Red reflex. What's your script? You got a red reflex. Yeah. I love it. It's great. When I was going through school, that was also what I said. So, same. Oh, magically my student has a 0.3 cup-to-disc ratio. Crazy. This is a tunnel pen. Okay, this is one of the ways we can check IOP if we're not using the puff test. This is a nice portable device that we have. The device itself, you'll numb the patient's eye, and you'll put the tip of this device right on the patient's cornea, and the device then will read what the IOP is. It has these fun little tunnel tip covers, kind of look like a tiny little condom. So. That's a tunnel pen. Tunnel pen in action. Remember to anesthetize your patient. Otherwise, they're not going to like it. Okay, you guys also have checked the anterior chamber depth. Okay, it's hard to check the anterior chamber depth just using a pen light, especially if you don't really know what you're looking at. When we do the lab, we can kind of show you again what that's supposed to look like. A better way to assess the anterior chamber depth is actually with the slit lamp, because you can see how deep the anterior chamber actually is with the microscope there. So we'll show you that too. A shallow anterior chamber has an increased risk for angle closure glaucoma, which we'll talk about in the glaucoma lecture. That's an ocular emergency that needs to be taken care of. This is what the slit lamp looks like. Okay, again, we'll cover this on Wednesday. Should be fun. I will be looking at y'all's eyes under the microscope, and then you'll be looking at each other's eyes under the microscope. Try not to have too much eye boogers or gunk on your eyes. Like, take a shower that morning, just scrub around your eyes a little bit. Otherwise, I'll jump. If you have epithelial defects, whether that's because you've got severe dry eye or you have a corneal abrasion or anything like that, we'll put a little dye in your eye called fluorescein, and this fluorescein stain will embed itself within the epithelial defect, and then we'll shine that blue light on the eye, similar to like using a Woods lamp, if you guys have one of those. Or there's these little things called bluminators, which are just like a little handheld thing. I'll show you guys that on Wednesday too. Those are very useful operationally because they can just go right in your pocket and you can assess the patient's eye as well. But that's what the stain looks like on the eye, patient with dry eyes. Any questions? Awesome. If you do have questions, just ask. Who's that? All right. We'll do some common visual disorders here. We'll get through this PowerPoint today. The things highlighted in bold are, obviously this is your PANCE blueprint, but this is what we're going to be talking about in relation to your PANCE blueprint. These are the topics for today, okay? Okay, ametropia is an eyeball that has no prescription to it, okay? Almost no eyeballs are actually emetropic. Almost every eyeball is either far-sighted or nearsighted slightly, okay? Also, for your reference and speaking abilities, it's not far-sighted with a D or nearsighted, it's sight, okay? Far sight, you can see things far away or see things near sight, okay? So hyperopia is far-sightedness and myopia is nearsightedness. So you might hear somebody say that person has a very myopic view on life, meaning they're only looking at things today and tomorrow, not things in the future. You should be a little hyperopic when you're using your brain, okay? All right. Astigmatism is not that bad. It's kind of like being nearsighted or farsighted. For whatever reason, there's a stigma behind the word astigmatism. Also, people will just call it stigmatism. It's astigmatism. And basically, patients with astigmatism are having an eyeball that's not just perfectly round. So think of like a basketball is a sphere, okay? That's what your cornea should look like. A lot of patients' corneas look more like a football, where it's kind of spherical in one meridian and spherical in the other, but the two spheres don't actually line up. That's astigmatism. So there's two light rays that are coming into the eye being refracted, and it creates just a little bit of blur or distortion. And a lot of patients with astigmatism, especially higher levels of astigmatism, will note that they've got glare or issues driving at night, because as the pupil dilates, more of that distorted cornea is what the patient's looking through. So that's just one of the side effects of that. And then here's good old presbyopia. Okay, we talked about that already. There are proteins in the eye called alpha crystallins inside of the lens. These alpha crystallins are what keeps the lens mobile and able to move, and also keep the lens clear. And your body naturally produces that alpha crystalline protein up until about the age of 40, and then that protein stops being produced. Your lens becomes rigid, and then you can't see things up close. And your lens also becomes not clear anymore, and that's called a cataract when your lens becomes not clear. So spoiler alert, you will need reading glasses in the future, and you'll have cataracts as well. The good news fairy today. A lot of patients will note that they just start holding things out further away from their face in order to see things up close more clearly, and then eventually their arm is not long enough anymore, and that's when they come see us and they get their reading glasses. So this picture is actually fairly accurate in terms of what patients do. He should just put his reading glasses on, because that would probably help. Okay, this is what the light rays look like when they're in the eye. It's not a great chart, but the myopia in letter B here, the light rays are actually coming to a focus in front of the eye. So if you put glasses there, that will bring that light back to the retina. Okay, farsightedness, those light rays are focusing behind the retina, so you need glasses to bring them up more. And then astigmatism, this is a great chart here. Multiple sets of light rays, as you can clearly see here. Obviously, that's such a clear picture. And glasses will help bring both of those sets of light rays. So there's two prescriptions cut into glasses for patients with astigmatism. Okay, how do we treat vision? Well, glasses, contacts. Okay, that's pretty common. And then refractive surgery we already talked about. Okay, PRK, LASIK, SMILE. With SMILE, they don't cut a flap and they don't remove the epithelium. Instead, they make a small incision in the cornea, and then they take a laser that actually cuts a little lens out of the center of the cornea, and they'll pull that little lens out through the little hole that they made, and then that reshapes the cornea. It's only used for patients with nearsightedness, because it actually just flattens the cornea, and that's how we reshape the cornea for myopic patients. It works really, really well. So if you can get SMILE, if you're nearsighted and you want refractive surgery, you should try to get SMILE, because the recovery is a lot better on it, and you don't have the dry eye issues that you will with LASIK and PRK, and you won't have the pain that you have with PRK. So SMILE. It's a good procedure. Okay. They don't do conductive keratoplasty anymore. Neither do they do radiokeratometry. Okay. This is why. This is what RK looks like. This was the first type of refractive surgery that was performed on patients. They take a blade and they cut little slits into the cornea. These are scars from a knife that was cutting the cornea there to try to reshape it. It's obviously not done anymore because there's a ton of scars on that patient's eye, and the corneas would start to develop a lot of irregularities. And these patients a lot of times would need corneal transplants, which isn't a great outcome for refractive surgery. Okay, this is PRK. We already kind of talked about that. They'll take the epithelium away and then zap with the laser. This is what LASIK looks like. Okay, they'll actually use a laser now, not a knife, to cut that initial flap. But they cut the flap, flip it over, zap, 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 put the flap back in place, and then you're good to go. And this is a picture of SMILE here. So they'll cut that incision where that femtosecond laser is, and then the laser actually cuts that little lenticule from the middle section of the cornea, and then they remove that little lens. This is conductive keratoplasty. I've never seen this before. It's pretty rare. It's not performed today here in America. But they would use these, kind of heat the cornea up, and it would shrink the cornea in certain sections to try to reshape the cornea as well. Obviously, that leaves some pretty gnarly scars too. And scars in the cornea aren't useful. It's hard to see through a scar. Here we have things called intacts. These are plastic rings that are implanted into the cornea to try to get more rigidity to the cornea. The disease called keratoconus, where the cornea loses its tensile strength and becomes like a cone, keratoconus, and then it causes a lot of visual distortions and potentially corneal perforations because the cornea becomes too thin. So surgeons would use intacts to try and reshape the cornea and pull it back into place. They don't use that as much anymore. They do corneal cross-linking, which we'll talk about here in just a sec. If you have eye trauma and you lose your lens, they can put a lens inside of the eye, in front of the eye. This is called an anterior chamber lens. This is not what they do for cataract surgery. This is not done all that often, usually again from eye traumas. You can do an ICL. Anybody have an ICL in here? Right, very good. So ICLs are for patients with high myopia, very nearsighted people, usually above like a -6. What were y'all? Above a -6? Yeah, did you know what you were? Okay, above a -6. Yeah, so not good vision, like the focal point is right here and everything else is blurry. We'll actually implant this lens behind the iris in front of the patient's lens, and it acts kind of like a contact lens within the eye. Pros to this are, if you don't have enough tissue on your cornea to reshape and flatten it, they can't do LASIK or PRK, but they can put this lens behind the eye and not have to reshape the cornea at all. So this is actually reversible surgery, which is kind of cool. Obviously PRK and LASIK aren't, because once you blast that tissue away, it's gone into the ether. Okay? But this is a newer procedure and very well received so far. So, corneal cross-linking, just talking about that. If you have keratoconus, usually they'll do this now, and this turns kind of a malleable cornea almost into the hardness of a Jolly Rancher. So I've seen videos where they'll take the riboflavin drops that they use for corneal cross-linking and put a drop onto like a donor cornea, and then they'll use the ultraviolet light and it hardens it, just like the light that they use in the dental office. And it hardens the cornea and it turns from this pliable substance into like rock hard. So they're doing this quite a bit, corneal cross-linking. It's been a great benefit to patients with keratoconus. Okay, obviously, with surgery, there can be complications. For example, with LASIK, they're cutting a flap, so your flap can come open if you have a lot of trauma to the eye. I will say, if you're doing enough trauma to the eye where you actually dislodge your flap, you've also screwed your eye pretty hard anyway, so that's not a good thing to do. It's not very common that flaps come displaced, but they can also have some cells that kind of grow underneath the flap. I think we may have a picture of that. And then obviously infection is a complication anytime you're doing a procedure, but really very few complications with refractive surgery procedures. It's pretty simple to do. Okay, you can get folds in the cornea that can cause visual issues. This is a picture of the cells growing underneath the flap. You can see these cells right here. That's not supposed to be there. It should be clear, but epithelial cells kind of grew underneath the flap, and that's kind of what they look like after the fact. Not super common either, and they can be treated. They'll just lift the flap back up and clean that all out and put the flap back down. Okay, sometimes flaps have to get sutured down. This is also not super common, but those are sutures. You guys done sutures already? No? These sutures are very, very tiny. This is usually 10-0 nylon, and they're like smaller than a hair, very wispy little sutures. So the cornea docs are the ones that do these. I don't do this at all, ever. That is far of my scope. Okay, sometimes you can get hazed with PRK, also not super common, but it can happen.
Do you do the PRK and the LASIK and stuff?
So, great question. No is the simple answer there. There are some states that do allow optometrists to do PRK because it's non-invasive, because they're not actually cutting anything. Oklahoma comes to mind, Kentucky comes to mind, I think Louisiana. Optometrists can also do PRK. But most of the surgeries for optometrists happen in Oklahoma. We also have the ability to do like a Chalazion incision and curettage in Oklahoma, and some other kind of cosmetic procedures there as well. The reason for that is that number one, that the AMA kind of dropped the ball and they didn't fight hard enough to not let optometrists do procedures in Oklahoma. But the other reason, the main reason, is that there's a lack of ophthalmologists in Oklahoma, and they're only located in a few certain areas. So the population doesn't have the ability to get to these ophthalmologists as easy as they do to get to optometrists. So that's why. Good question. But typically, no, we don't do surgeries at all. That's ophthalmology. Okay, here's your glasses prescription. This is what we're using to get your glasses prescription. This is called a phoropter. Okay, this is also very easy to do, although you probably never do this. I think it's good for y'all to know what a glasses prescription means. So there's three main numbers that we write in a glasses prescription. Again, and we do it for each eye. So OD, again, is right eye, OS is left eye. And on the right eye for this patient, there are -3. That's the sphere power. So minus or plus is if you're farsighted or if you're nearsighted. So minus powers means the patient's nearsighted. Plus powers means they're farsighted for that first number, okay? And then optometrists like to write in minus cylinder, meaning this middle number here is always going to be a minus number if it's written by an optometrist. Ophthalmologists use plus still. They're weird, and they don't refract often because they would rather do surgeries. So this is the amount of astigmatism that this patient has. So the middle number is your astigmatism number. So the higher that number is, the more astigmatism you have, the more irregularly shaped your cornea is. And this last number deals with the axis of your astigmatism. So all astigmatisms are going to have two powers that are coming into the eyes, and those powers are usually 90 degrees apart on the cornea. And so the axis is where your astigmatism is at its highest elevation. Okay? If you don't remember all that, that's fine, but those numbers actually do mean something. The first number again is the sphere power. That's going to be the nearsighted or farsighted. The second number is the amount of astigmatism that you have. Okay. Sometimes you'll have patients that have what's called an add power, and that add power is the additional power that we'll put in to like a patient's bifocal or a progressive lens. The add power is what helps see them see things up close. Okay, eyes can deviate. Hopefully they don't. If they don't deviate, then they're termed as orthophoric, meaning both eyes point in the same direction. They can be heterophoric, which is also kind of normal, where the eyes either want to, when your eyes are closed, they're either going to be kind of pointed out a little bit or pointed in, or maybe one's pointed up a little bit. That's also not necessarily a bad thing. Because when you open your eyes, hopefully they'll just snap into place. Most people are actually exophoric, so if you close your eyes and you open them real quick, things are a little bit double and it snaps right into place. Usually eyeballs are sticking out just a little bit, exophoric. Atropia, heterotropia, that bottom section, that's not normal, okay? So atropia is also called a strabismus, okay, or an eye turn. So if one eye is looking right here, and this eye is looking like right here, kind of like a crazy eye, okay? You should probably look at the eye that's looking at you. Try not to look at the crazy eye. Sometimes it's really hard not to look at the crazy eye. But the eye that's looking at you is the one that's actually seeing something. Very few people, I remember my 4th grade teacher had a crazy eye, and he'd always be, one was pointed out here and one pointed here, and he swore that he could interchangeably use his eyes. I don't think he actually could. I think he was just pulling my chain there. But he said that he could see us over here. He's an interesting dude. Tropias are not normal, okay? Patients are probably going to have double vision. If one eye is pointed here and this eye is pointed out like this, that patient's going to be seeing two images. The brain is going to say, I don't want to see two images because I don't like that at all, and it's going to shut off the crazy eye, okay? So you're only seeing through the one eye that looks forward. That's called amblyopia, which we'll talk about in a little bit here. We want to prevent amblyopia as much as possible. So if you see a kid coming into your clinic, like under the age of 10, and one eye is pointed in, usually on kids you'll have esotropia. So one eye is looking straight, the other is pointed in. We want to try to refer that patient to ophthalmology to get strabismus surgery as soon as possible. Because there's a good potential if that patient's treated young enough and we can get both eyes tracking in the same direction, they'll have a decent level of binocularity, which allows them to see in 3 dimensions. If they don't, then the brain is going to hardwire itself in so that it's just going to be looking out of the good eye, and it's not going to be looking out of this this turned eye, okay? And then that patient's going to go through life with a decreased visual acuity, best corrected visual acuity in that turned eye, and also they won't have any depth perception. You can't have depth perception if you're only looking through one eye, okay? You need both eyes for that depth aspect. So if you have a kid coming into your clinic, please, and they've got an eye turn, please refer them to ophthalmology so that they can get the proper treatment. We really can save a lot of these kids' vision from amblyopia. Okay, just talked about orthophoria, both eyes pointed in the same direction. Heterophorias, we talked about that too. If you want a strabismus simulator, you can go to that link on the American Academy of Optometry or Ophthalmology. I don't know which AAO that is. This is kind of a cool simulator. We can see some examples of strabismus here, tropias. Okay, kid on the left, the patient's left eye is turned in. See that? The old Gosling right there. He's got a little bit of an eye turn. Looks like that left eye's turned out a little bit, or that right eye is turned out. One of the eyes is turned out there. And then the girl on the right, her left eye is turned up. Okay. These are all pretty obvious. It doesn't take an eye doc to know that something is not right with these patients. You can use what's called the Hirschberg reflex. So you can see, especially in this kid here, there's a light reflex in both pupils. You can see the normal eye, that light reflex is smack dab in the middle of the pupil. In the abnormal eye, the light reflex is off to the side. Okay? And you can kind of measure how much of a prism diopter change that this patient has based off of that measurement. You guys shouldn't ever worry about that. You should just see, I'm doing the Hirschberg reflex, and they're either normal, straight on, both in the center of the pupils, or they're abnormal, and one is not functioning properly. And again, in which case, punt. Okay, get into optometry ophthalmology. Right, so strabismus equals atropia. Okay, strabismus is atropia. It's a manifest condition. Okay, you'll see it when you guys are doing cover test. You guys do cover test? You guys feel good about cover test? Like you know what you're looking at when you're doing cover test? Okay, if you don't, and there's a good chance that you don't, let us know when you're coming into the lab, and we can kind of give you a rundown on what you should be looking at when you're doing the unilateral and the alternating cover test. It's not very intuitive at all. Cover test takes a long time to master, to figure out what you're actually looking at. But it's a very useful test, again, if you have young kids that are coming in and you're trying to prevent amblyopia if they have a strabismus. So let us know if you want more hands-on practice with that. Okay, this is an example of a left esotropia. Actually, yeah. This is an example of a left esotropia, okay? Not in letter A, that looks pretty normal to me. But letters B through D are pretty obviously not aligned properly. Okay, the right esotropia here, that right eye's turned in. So this is what you're going to do on the unilateral cover test. Okay, you're going to have this patient looking at you all crazy-eyed. You're going to cover this right eye, and then that left eye, I'm sorry, you're going to cover the left eye, and that right eye is going to snap back into where it's supposed to be. Okay. Normally, when both eyes are uncovered in that top picture, that right eye is not turned on. Okay, the brain is shutting off that eye completely because again, the brain does not want to see double. Okay, but as soon as you cover the good eye, then the brain's like, oh crap, we're black, but we need to see, so it's going to turn that right eye on, and then that right eye is going to snap out. Okay, that's the unilateral cover test there. And then as soon as you uncover, that eye is going to pop right back into place. Okay, so these patients will need a strabismus surgery. A lot of these strap surgeries are only done on kids because we're trying to prevent that amblyopia from happening. Amblyopia is when a patient is not able to see 20/20 with any means of correction. So there's no level of glasses I can give this patient to get their vision to 20/20. They're going to be like 20/40, 20/30 best corrected. And that's because the brain, as it's being hardwired in the visual system, it doesn't send all of the hardwiring signals that it needs because that eye isn't working like it's supposed to. Okay? It's going to send it all to the good eye, and the other eye, it's going to conserve its resources and send that brain power elsewhere. Okay? So in adults, if they have an eye turn like this, they won't do strap surgery as often unless it's like for cosmetic reasons, because that patient is already amblyopic and they're not going to be seeing through that eye anyway. They might just want it for cosmetic reasons because they don't want the crazy eye. Okay, don't worry too much about this. Strabismus is bad, whether it's concomitant or inconcomitant. We want to try to prevent amblyopia at the end of the day, and strabismus can cause amblyopia. kid has esotropia, allegedly. Looks like maybe a little bit of a vertical deviation as well. I would say that this patient's left eye is turned in just a wee bit there. Maybe also down just a little bit. There are more pictures of tropias. And again, tropia is a strabismus. All right, we can have nystagmus. Nystagmus is just a jerking of the eyes, kind of constantly beating around. So if your eyes are constantly moving like this, it's hard to see very clearly because your eyes are always moving. So patients with nystagmus, a true nystagmus, will have a decrease in their best corrected visual acuity because they can't focus on anything because their eyes are always kind of moving around. Okay? Nystagmus is induced sometimes by physiological conditions, also by drugs. Okay, one drug that can induce a nystagmus is alcohol. Okay. You can get that's why cops will do the muscle age test when you're suspected of a DUI. I've never had that test done to me. I've only seen it done on cops. Right, but that's what they're looking for. When a patient is drinking and they get their eyes moving over to the side, their eyes will beat when they get over to the side. Okay? If they have a true nystagmus, also if they've been drinking. Okay? So that's what the cops are looking for. So if you have been drinking and you stupidly get into a car and a cop pulls you over, might say that you have a nystagmus. And that cop will probably not believe you, but at least you know. Okay. Don't drink and drive. Who's recording? Don't drink and drive. Okay. Said it. All right. So again, it can be from drugs or not from drugs as well. If it's from drugs, the way to treat the nystagmus is to get off those drugs. If it's not from drugs, then it's much harder to treat nystagmus. And those patients are the ones you feel bad for because they don't have very good vision at all. Usually those are almost legally blind patients. So if you have a patient with nystagmus, you're going to do a workup and you're going to note that a lot of these workups are very similar and that you're going to take a good case history, you're going to ask all the important questions of that patient, you're going to do, for almost every patient, some level of visual acuity, and then refer. So you're going to do for a lot of these conditions. Okay. Spoiler alert, you're going to be hunting a lot to ophthalmology. And don't feel bad, because I hunt a lot to ophthalmology too. If I can't, if something's like needs surgery or there's something really wrong with the patient, and I have ophthalmology at BAMC, and there's world-class ophthalmologists there, I'm just going to punt them, because it's better for the patient. Treat the underlying etiology for nystagmus. It's usually a good way to treat it. Okay. All right, here's amblyopia. Again, I'm harping on amblyopia because you guys are going to see kids usually at a higher frequency than I'm going to see kids. Okay. And the kids are the ones that we can really prevent amblyopia in. So, again, the definition of amblyopia is in layman's terms, the inability of an eye to see 20/20, okay? Because the neural pathway is just not there. The brain does not want to do it because it needs to work too hard to get that neural pathway there. So there's three main types of amblyopia. There's refractive amblyopia. We already talked about strabismic amblyopia and occlusive amblyopia. So if a patient has a large difference in refractive error in both eyes, let's say one eye has like a plus 0.25, which is almost nothing, and the other eye is like a plus 6.00. That's a lot of farsightedness. The brain doesn't want to focus that plus 6 eye to see, okay? So it's not going to, because the other eye doesn't need to be focused at all. So what those patients need is glasses, okay? So if you have that kid coming in and you're doing a little auto-refraction on those kids, and you've got no prescription in one eye and a ton of prescription in the other eye, please refer that kid to optometry so we can try to get that kid glasses. Because if we get them glasses and they wear them, then we can correct the vision in the one eye, and then the brain is still going to send the full neural signals in the optic nerve to both eyes. If we don't, then that eye is going to become lazy, and they're not going to be able to see out of it. Okay? And then they will have deficit. Yes?
Is that the same as monovision? Or is it like because it's opposite?
Monovision is not the same as amblyopia. Monovision is a lot of times what we will prescribe for presbyopic patients that can't see up close. We'll correct one eye for distance and one eye for near, which also eliminates your depth perception, but you still have 20/20 at both distances. That's monovision. Good question. Strabismus, again, we talked about, if you don't correct that eye turn, the brain is not going to send the signal to that eye, it's just going to turn it off. And then if you have a big scar in your cornea, if you're born with a corneal scar, if you have eye trauma as a kid and that cornea scars, or if you've got congenital cataract, if you're born with an opacity in your lens, then we need to perform surgery. And again, by we, I mean not me, ophthalmology needs to perform surgery to get rid of that, that blockage, that occlusion, so the patients can see, so that both eyes start working correctly. Okay. All right, this goes more into amblyopia here. Basically, for y'all to remember, if you have a kid under the age of 10, because under the age of 10 is when that visual system is still developing. If you have a less than 10-year-old and they have a difference in the eyes, or you're testing their visual acuity and one eye sees 20/20, the other eye sees 20/50, then have that kid get an eye exam so we can try to fix whatever's wrong with it. Okay. All right. On kids, if you have a kid coming into your office, perhaps they don't know their letters yet, so you'll put up a shape chart like this. Okay? You've got a birthday cake, a duck, a hand, a truck, a person riding a horse, and that is a telephone. Okay. Kids have no idea what that phone is, exactly. Kids also have an imagination. I had a kid tell me that the birthday cake was 3 people in a hot tub. Maybe just squint a little bit, it's kind of what it looks like. Okay. The other ones are kind of easy for kids. The hand is really easy, a truck, the bird, the horse. But yeah, those other two, less so. Okay, this is a picture of what a decreased red reflex looks like. In normal patients, the red reflex should be uniform in both eyes. Okay, if you have a decrease in the red reflex, that's typically the bad eye. Okay. So, like in the upper left picture, the patient's right eye, or if you're looking at it, the eye on the left has a nice red reflex. The eye on the right, that one looks weird. Okay. Don't confuse a decreased red reflex with what's called leukochoria. Leuko meaning white, chorea meaning pupil. So white pupil is a bad thing. That can be indicative of a tumor in the eye, retinoblastoma in kids. That can be indicative of congenital glaucoma in kids. Okay, so if a kid has a white pupil, you want to refer that to ophthalmology as well. But they should have a normal red reflex, and if they don't, also probably refer that kid out. So how do we treat amblyopia? Again, you guys probably are not going to be treating amblyopia, but when you take your pants exam, they probably want you to know how to treat amblyopia. So it's pretty simple. How do we treat it? If it's refractive amblyopia, we give that kid glasses to correct their vision. Okay, so if one eye is a +6, one eye is plano, we're going to give that kid glasses so that hopefully both eyes start working as they're supposed to. If it's obstruction causing amblyopia, we're going to do surgery. Again, I'm not. Ophthalmology is going to do surgery. Cataract surgery, try and clear that scar on the cornea, or if the lid's drooping, they'll do a lid tuck on that patient. And then strab, strabismic amblyopia, how do we treat that? They'll either get strab surgery, so ophthalmology will go in and tweak those extraocular muscles to align them where they're supposed to be, or we can try patching the eye. We'll actually patch the good eye to force the bad eye to work, and there's a couple other things that we can do, but surgery is often performed for patients with strabismus as well. Okay. So again, if a patient's over the age of 11 and we're trying to treat amblyopia, it's probably not going to work. Usually the visual system is already hardwired in. So we're really looking for those 10 and under patients because that visual system is still kind of finalizing itself. This is what refractive esotropia looks like, okay? So this patient here obviously has an eye turn, okay? That left eye is turned inwards, in meaning ESO means in, okay? Esotropia. EXO is out. Okay, so left esotropia. But the reason that eye is turned in actually has a refractive component to it. So this left eye is probably like a +6. The right eye is probably plain out. Okay, so we'll get glasses for this patient and put the glasses on, and all of a sudden now that left eye swings to where it's supposed to be. Okay, this patient didn't have surgery, they just put the glasses on, and now they're able to see out of both eyes. Okay? That is why we want to get these kids in ASAP. Okay, we can also patch kids if they have a strabismus. Kids hate patches, and they don't often wear them. And parents, especially like this generation of parents, do not want to force their kids to do anything. So patching is not ideal, but that is an option as well. We also have eye drops that we can use for patients like this. But really, it's educating the parents that this is very important, that your kid needs to wear this patch, or they're not going to have depth perception, and they're going to limit their career abilities greatly. Okay. That is really all I have. This YouTube link, I don't even think works anymore. But if you're nervous for this exam, don't be, because it's not going to be that bad. Here's some notes from the season TA. These are good kind of pearls for y'all coming out of PA school. So slit lamp skills were not great. It's probably not going to change. You'll at least have used a slit lamp or have had the option to practice on a slit lamp. Whether or not you take advantage of that during lab is kind of up to you. But I would. They're really handy to use, and they're really pretty fun. And then when you're in clinic, like at the JMC, for example, here, optometry is right down the hall from primary care. So I worked at the JMC prior to teaching, and I had PAs ask me if they could look at stuff all the time. I'm always willing to have you guys do that. So make friends with the eye docs. We'll try to make friends with you. It's a nice symbiotic relationship. It works out pretty well. It felt like the ability to view the retina during the exam is lacking. Well, yeah, if you're doing DO, it probably is. So don't feel bad about that. Your ability to view the retina is probably always going to be lacking, okay? And again, that's because the DO does not work very well. What we use is a lens underneath the slit lamp, and I can kind of show you guys that on Wednesday for the lab. But that also takes a ton of practice, which you guys are probably, to be honest, probably not going to do. What works best for people that don't have the slit lamp skills is to get a fundus photography. So a machine that actually takes a picture of the back of the eye. Those work really, really good. And they're not difficult to use. So that I would recommend, if you're at like a retina practice or ophthalmology, try to get familiar with using machines there. That helps a lot to see things inside of the eye. Okay, PEDS, vision testing, potentially life-saving, life-changing. Talked a lot about amblyopia and prevention there. First time seeing a subconjunctival hemorrhage, freaked out, okay, and you might as well. Subconjunctions are just bleeding underneath the conjunctiva. I think we have conj on Monday, so I'll show you what a subconjunctive is. Your patients are also going to be freaking out. So it's going to be up to you to understand that it's just a subconjunctive, which is essentially a bruise on the eye, and you shouldn't freak out, neither should the patient. Never freak out in front of a patient. Also, if you don't know what it is, don't Google it right in front of the patient either. Okay? Like step out of the room, either ask a colleague or Google it outside of the room. I've done that before. Conjunctivitis, we're going to hit that hard. You guys are going to be treating a lot of conjunctivitis. This is the most common eye meds. Polytrim is an antibiotic. Moxifloxacin is also very common. Vigamox. Refresh Plus is artificial tears. We hand that out like candy. Never RX to topical steroid, and I would recommend that you all never prescribe a topical steroid either, because you should be monitoring intraocular pressure if you're prescribing a topical steroid, and you guys are probably never going to monitor intraocular pressures. So don't prescribe a topical steroid. So if you see that answer on an exam, probably not the correct answer. Okay. Let's see. No entrance VAs were taken. Yeah, that's not fun. So remember, if you have a patient complaining of eye issues, try to remember to take visual acuities. It sounds super basic, but it really is one of the most important things that you guys can take as a technician or as PAs. Okay. So, all right. Any questions from that? My last exam or last lecture for today? Well.